welcome to our Quality and Patient Safety Committee on February 16th. I just want to remind us that pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. And to streamline, we've combined combined action items into one combined motion. So only one roll call vote for action items will be needed during the meeting. Let's move forward with I'd like to call the meeting to order. So Madam Secretary, can you please call the roll?
Director Garza.
Present.
Director Story. Director Story.
Present. Present. Yes.
Thank you. And Chair Kim.
Present.
And for the record, those directors also present. Director Harrington. Director Harrington.
I know I saw him.
He may have stepped away. Director
Okay.
Sorrell.
Present.
Thank you. You have a quorum.
Great, thank you. I'd like to say that our next meeting for the Quality and Patient Safety Committee is scheduled for Thursday, March 23rd at 10:30 a.m. I'm going to move to our second agenda item. Madam Secretary, has anyone registered to provide virtual oral testimony or submitted written testimony to be included in the record?
Yes, we've received one registration for oral testimony from Dawn Cole, and I believe she is present. Are you present, Dawn Cole?
I am present.
Excellent. So you have 3 minutes, and I'll give you a reminder as when 30 seconds are remaining.
Okay, so good morning, everyone. Thank you for the opportunity. I want to speak on behalf of my mother, Rosemary Richard Sitnor, who was a patient at Cook County Hospital. She was being treated for cancer and radiation, and she had to be hospitalized on Sunday, January 28th. We stayed in the emergency room 14 hours. After a 14-hour stay in the emergency room, she was then admitted into the hospital. We had to wait 3.5 hours for a bed. After waiting for a bed in a room, because she had to be in isolation because she was neutropenic, meaning her white blood cells were very low. And she needed to be at Cook County so that she can continue her radiation. She had 2 weeks of radiation left. When we took her upstairs to the room was absolutely filthy. There was dust so thick, it was like fur on the vents, on the TV cords. The floor was dirty. I will say it was dirty because it needs to be top scrubbed, but it was also dirty because there was debris left from the nurses that had the previous patient. When we found out from the charge nurse and everybody that when I called patient relations and they came up, they said someone had put this room in the system as being cleaned. I am coming to you talking about the systemic issues. I took care of what needed to be taken care of for my mother with the doctors, the nurses, the EVS. But the fact that a room could be that dirty for that long, that wasn't just from one discharged patient. The room was filthy. The curtains were soiled. The bathroom was dirty. It was just dirty. And there were things in the care that were also an issue. I submitted a full report to patient relations, and I wanted to bring it to this board's attention because what I saw on that floor, and this is in 7 South, there are not a lot of patients that have family members with them who can help speak up for them. My mother couldn't speak up for herself because her cancer was in her mouth, and so she had to have surgery. But I wanted to bring this to the board because you have people in places assigned to jobs, but they only are doing their job when someone is calling. And largely because a lot of the people that are coming to the hospital, their family members are not with them or they're too ill to speak up for themselves. Nobody's calling. So I just implore you, my mother is a retired teacher. We are educators, we are taxpayers, we are lifelong residents of the city of Chicago. And on behalf of those citizens of Cook County, we need better care. We need somebody who's going to watch over people and make sure people are doing what they're supposed to do, especially people who don't have someone there with them. So that concludes my conversation for this morning.
Well, I want to take a moment to thank you for sharing this with us and pushing us always to do better for our communities. And thank you for telling us about these unfortunate events.
And I'll also say, there seems to be, from the care she received from the outpatient clinics to the inpatient side of the hospital, that's the reason why I brought her back to the emergency room, because her doctors and Clinic D, the radiologists, and the nurses, they took such great care of her. But I have since, she was discharged this past Sunday after 2 weeks. I've had to since put her into another hospital to continue her care because I just could not rest with her being there, with me having to be at the hospital all the time.
Again,
So
thank you for sharing your story. And I think all of us wish you and your mother, really the best care and best health that she can receive. And again, thank you for your bravery in sharing this.
Thank you all.
Madam Secretary, are there any other testimonies, written or oral?
No, Chair Kim, that was all.
Okay. Thank you. Let's move on to agenda item 3, which is our reports on quality and patient safety. Yes.
Chairman, could I interrupt?
Yes.
Real quick. Can we get a follow-up from management on this particular case? She said that she had submitted a report to patient relations.
I think that would be a great idea.
Yeah, Director Story. Director Story. This is Lynn Dang. I am reaching out to patient relations concerning this, and also, she would be a great member for the Patient Family Advisory Council. So we'll probably reach out to her to see if she would be willing to be a participant of that PFAC as well. But I am writing an email to patient relations. Thank you.
Great.
I see one other hand up. Oh, but I can't see the full name.
CW.
This is Craig Williams. I'm the interim chief hospital executive for Stroger Hospital. And I just want to say, obviously we take that testimony very seriously. I'm in process of developing an action plan to address this with our environmental services team, and we can certainly report back to this committee at a follow-up meeting.
That would be very helpful.
Sure.
I think we'll move on to our agenda 3, which is our report on quality and patient safety matters. And again, these reports are informational only. So we're going to hear about the HRO dashboard. Eric Makaitis, Chief Quality Officer, please go ahead.
Thank you very much, and good morning, everyone. We'll start, as always, with our 30-day readmission.
Good morning, Dr. Makaitis.
Oh, yes. Hello.
Good morning.
Director Story. Hello, good morning. So we will jump in for 30-day readmissions. I'm happy to share that it came down again this month. We dropped from 10.45 to 9.38% overall readmission. Puts us better than target for the month, and overall year to date through October, our 30-day unplanned all-cause readmission rate improved to 9.7%, which is right at our stretch goal. Just kind of digging in a little bit, our heart failure readmissions, they were a high outlier. If the group remembers, we had about a 20% readmission rate in September. That's decreased back down to 7%. On the next slide. We have our medical case mix index. We saw a very slight increase, 1.21 to 1.24, which does meet our target goal for the month. And on the next slide, we'll see our surgical case mix. That has also increased from 3.05 to 3.12 October to November. We continue to focus in with the CDI team, and we have our clinical documentation team, including Dr. Alabik, here to present to this group later. Next slide is our patient experience. Happy to share that that also increased. We went November to December from 65% to 70% for recommend the hospital top box at Stroger. And year to date puts us at 71.1%, which puts us at the 59th percentile. And our last slide, again, an improvement, and really, I think, kind of the headline story for all of these metrics, our A1C control, our HEDIS, which is our ACHN metric. As of November, it's continued and is now exceeding the goal of 24%. They've now come down to 23% of the patients out of diabetic control. And our last slide is just definitions. And that would conclude my report. Thank you.
Thank you, Dr. Makaitis. Are there any questions? Okay, well, we are going to move forward with regulatory and accreditation updates. Leslie Frayne, Associate Chief Quality Officer, is going to present.
Good morning, everybody. Before I go on to the regulatory update, I have two introductions. You can see I have somebody sitting here with me. This is Dr. Riley Taylor. He's one of our residents here at Cook County Health, and the quality department has started a 2-week rotation for residents to come through the quality and patient safety department to learn more about what we do. So this is the first time we're having this rotation, so I'd like to welcome her to our board meeting today. My second introduction is Cynthia Fish. I'd like to introduce her to the board members. She is our new Director of Regulatory and Accreditation. She's been with us now, this is week 3. Cynthia comes to us with many years, about 15 years of experience in quality, safety, and regulatory. And she was most recently at St. Francis Hospital, where she was the Director of Quality and Patient Safety. So we're really glad to have her on board joining our team. And going forward, she will be presenting you with the regulatory updates for the system. So Cindy, if you just want to say hello and welcome.
Thank you. Glad to be here.
All right. Okay, so on to the regulatory update. So for Provident, as we all know, we're preparing for their triannual survey that will be occurring this year, not in 2024. We have already started our weekly meetings for survey readiness, and we had a mock there, and we're already following up on those survey findings, leading us into our survey readiness. And then we will move forward with a chapter lead model and mocks and tracer survey follow-up findings to get us ready there at Provident. We are also expecting the CAP in 2023. Our next slide for Stroger.
Excuse me, Leslie.
Yes.
Excuse me. I'm sorry, I'm on my phone, so I don't mean to keep interrupting you all inappropriately, but
oh, you're fine.
I've asked for a copy of the mock survey. It's but it's been several weeks now, and I've been asking for that to be shared, and I haven't received a copy yet. Can you help facilitate that? I'm sure other board members would love to see that. I can't speak for other board members, but I know personally I would like to see a copy of the mock survey.
So Director Story, Craig Williams and I touched base earlier this week, and he shared that request. Yes, we do have it. What we wanted to offer to you and anyone else who is interested is not just the update, but also kind of what we're doing to mitigate and steps forward beyond just the mock. Is that so kind of more of a bigger presentation for all of you? Sorry.
So what does that mean in terms of time frame? Is that next week, 2 weeks?
If you can give us a couple weeks, if we could get maybe 2 weeks, is that Craig and Israel? Is that does that work?
Works for me.
That's fine, Dr. Kim. If the record could reflect that, Debbie, that the board of directors or other members of the board would receive a copy in a couple of weeks, that's fine.
Yeah, we will note that. Thank you.
Great, thank you. Okay, moving on to Stroger. So we are expecting our stroke certification survey, and I have down here that we will receive that notification. I did receive that notification this week, and our stroke survey will be next week on February 23rd. So the entire team has been alerted. We've already been working very hard in preparing for that. So kind of like all those last minute things are happening, and we're getting ready. So we will have Joint Commission on site here next week for that survey. We continue to work on our trauma designation survey readiness and preparation. Not sure on the date. We just recently got some staff hired in place to, help us move forward with the preparations for that, because it's a very big undertaking, but something we very much want to do. And then we're still waiting on Belmont Cragen since we've opened that, and at this point, we're expected that to be rolled into our Joint Commission triannual survey at Stroger. And I believe that is it. Any other questions? All right, thank you.
Thank you, and welcome aboard to the team, Ms. Fish. Our next update is HRO clinical data from documentation work group. This will be reviewed by Dr. Michael Alabik and Letitia Arnold.
Yes, good morning. Thank you. Can everyone hear me?
Yes.
Yes,
Great.
good morning.
Good morning. Thanks for having me. I'm just letting everyone know our metrics here just to keep in mind as we move through the presentation. If we can go to the next slide. This first one here is showing our overall case mix index all the way up through November 2022, the last month that we have data in the Vizient work group. Looking over these 12 months here, 7 times we've met or exceeded our goal, 5 times failing to meet it, with our most recent one showing that we did meet our goal in November of 2022. We can go to the next slide. Medical case mix index, for the most part, with only a few exceptions, we are meeting or exceeding our goal, as well as meeting and exceeding those large specialized medical centers to which we're comparing ourselves. But with that said, a hospital's case mix index is pretty much predicated on the surgical case mix index. We can go to the next slide. So as you can see here, in September, October, November, we met our target and sometimes met our stretch or exceeded our stretch, as well as exceeding the other large medical centers to which we're comparing ourselves. This is the first time that we've had 3 consecutive months of doing this outside of COVID, I think, since we've been tracking this data. So this is very promising development. We can go to the next slide. All service lines, when we take an expanded view from 2018 all the way up to the last quarter, we had data in 2022. The overall trend is up, as you can see, starting from 1.59 to 1.73, near our goal as a hospital. And we can move to the next slide. So this case mix index is predicated on how well we can, quote unquote, capture the illnesses that our patients have. We tend to believe that we should be somewhere probably around the 70th to 75th percentile for the Vizient work group. Here you can see the capture rate in medicine, hovering somewhere around the median for the most part for most of the months. We can go to the next slide. And here you could see it surgical. Whenever the capture rate goes up, your case mix index will go up in kind. Just so everyone's aware, for the capture rate to go up, we're talking about capturing usually medical comorbidities. So even surgical patients need to have their medical issues captured in the documentation to ensure we're truly relaying how ill our patients are. We can go to the next slide. So with that in mind, there's a success story that shows that medicine and surgery can collaborate to improve our documentation. We did a study where we looked at embedding an internal medicine hospitalist along with the vascular surgery team. We looked at data pre that intervention and months post that intervention to see, did things change? And indeed they did. The case mix index, so the complexity of the cases went up, the capture rate went up, and while the length of stay raw went up, the index length of stay actually went down because sicker patients are anticipated to be staying longer. The mortality index also went down. So I think this illustrates how important it is to make sure that medicine and surgery are collaborating to capture the medical comorbidities that our surgical patients have. We can go to the next slide. My impressions, taking away looking at this data, surgical CMI capture rates, they are showing sustained improvement. And I think that has a lot to do with collaborating together. The hospital-wide CMI will always be predicated on the height of the surgical CMI. So to make sure that CDI specialists, internal medicine, hospitalist specialists, and surgery are collaborating, I think is essential for sustained success. And I will continue to state, I believe resources are needed to implement that change and make sure that we can assist our surgeons in real time with their documentation. That concludes my presentation. Thank you.
Thank you. I see one hand up. Oh, Director Harrington.
Yes, my question is, you say resources needed. Could you be more specific?
Yeah, so I would leave that up to Dr. Makaitis to make the final call, but I believe there does need to actually be a person embedded with surgical teams as they round, as we onboard our house staff and our attendings to get into the idea of what actually needs to be documented to capture these conditions. What happens now is typically people are getting education in lecture format, and then they may have someone query their charts after the chart was written. It seems that attendings seem to catch on much better when someone in real time is looking at their notes and saying, you know, you wrote this, it should have been written this way instead. And that requires a warm body.
Okay, so let us know if that occurs, and if it occurs, if there's any change in your data.
Sure, will do.
Director Story.
Thank you, Chairman. This might be a question for Dr. McCabe. Can you tell what's the skill set of the CDI personnel that y'all are currently utilizing?
So currently, I believe they tend to be nurses. This is actually going through our revenue team. But yeah, I believe they're primarily nurses. We are looking actually to onboard a physician expert who has from physician advisory as well as CDI, who could really engage, as Dr. Alavik was saying, with our clinical teams, kind of be at elbow, really coaching, and not just for appropriate coding, which is what we see reflected in CMI, but also in our statusing, so that our patients are placed in the right status when they're in-house. Right now, Dr. Batosho is really really shouldering all of the work and doing an incredible job. But he really is a party of one, trying to kind of move a mountain here. So we're trying to bring in some help for him as well.
Dr. Makaitis,
Yes.
throughout your career, have you ever utilized FMGs who were in transition in their careers to function as CDI?
Briefly in my last role, we did have a regional person who was an FMG and covered the CDI work. He was a physician, not board eligible, not licensable, and took that as a career.
Do you see that as a potential option, piggybacking on Director Harrington's comment about resources? Is that
Potentially,
a potential
yes.
source?
Yes, potentially. In fact, the person we're speaking with is kind of in that scenario.
Great. Thank you very much.
I don't think there are any other hands up. So thank you for your presentation, and we will move on to update on CCH specialty care, particularly access, wait time, and referrals and review. And this will be presented by Ileana Mora, Chief Administrative Officer of Ambulatory Services.
Good morning. I want to start by sharing some
Good
facts.
morning.
Good morning. Sharing some data on the work that we've been doing regarding specialty referrals into the system. So this is a chart giving you data on where we were back in FY19 in terms of the number of referrals that we had waiting in queue for specialty appointments, about 20,000 back in 19. You can see that was cut in half by FY20 Q4. And then you can see further that we've cut that beyond half, further than 50% in the last quarter of 22 to about 4,900 referrals in backlog. Significant work has been done. I'll walk you through the actions steps we've done, but first walking you through the data. So then we look at the next slide, which is the patient wait, the actual time that a patient waits from the time they receive a referral to the time that they are actually get their appointment time to come in. So you'll see that back in FY19, that was a wait of close to 70 days from referral to the appointment to date. And we've reduced that a little over 40% to around 41 days for a specialty appointment. As we all know right now, probably in our own lives, the wait for any specialty care is quite a long length, no matter what system we're in. So we feel good about that reduction wait time and where we're currently at the average. If we go to the next slide, I wanted to give you a sense of the specialty clinics where
I might interrupt for 1 second. I see Director Harrington has his hand up, and if it's about an earlier slide, maybe you can address that now.
Of course.
Yeah, my question is about slide number 3. You go back to number 3. Yeah, I see the significant drop occurred just around the time we were facing COVID, and it's continued to drop. Do you think COVID has had anything to do with that, and these numbers will go back up? I mean, I'm just speculating, but it's interesting to see that trend and that dramatic trend down. And the messaging with the onset of COVID was not to go to the hospital.
Yes, certainly that's part of it, but I'm going to walk you through the action steps that I really think are part of what had another significant impact to it. But yes, of course, the pandemic did have some.
Thank you.
All right, wanted to give you a sense of the backlogs that have seen the greatest reductions. As you know, we have a very large ophthalmology practice across Blue Island, Provident, and Stroger campus. We saw big decreases in our eye program at Sangstack, as you can see from there. Also, podiatry is a very busy clinic as well, given that it's connected to diabetic care as well. Surgery, we saw reductions across in Stroger. We also saw hand surgery reductions at Stroger as well. And in pediatrics for GI also at Provident, and then of course HEMONC at Stroger. So good amount of reductions here. Again, I'll walk you through in a minute what were the actions taken. Moving on to the next slide just gives you a couple of more clinics where we saw significant reductions in the backlog from orthopedics in particular. Very busy clinic, like ophthalmology, among our busiest clinics, able to see major reductions there. Again, I will walk you through the why and the how. Musculoskeletal, also pulmonology, neurology, pain, and we saw very, very good reductions in all of those areas. So let me walk you through a little bit on the next slide as to how we got here. So if you look at the top left corner, number 1, this was a lot of the work Director Harrington, and big credit to Ratna Kanamuri and the clinical team and Dr. Irons for their work here. When we first started the journey around looking at the referral backlog back on FY19, we did notice that there were a huge, and also from feedback from our own specialists, we did realize and review that there were a good number of referrals that really, with proper guidance from a specialist, could be managed in the primary care setting with guidance to the primary care provider. And so a clinical decision support tool was developed whereby if I was referring a patient for vascular, for veins, or for something that potentially didn't always have to go to the specialist. There were a set of questions that the specialist, with Dr. Irons and Ratna, our leaders, worked with the specialist to have a set of questions that they would ask the primary care provider that would then essentially create the algorithm of saying, okay, this does not, based on what you're answering, this is what we recommend how you manage this patient in the primary care home, and would send the list of recommendations. And or if the list of questions led to, okay, absolutely, based on what is being answered, absolutely deserves and is in need of a specialist, then automatically then the specialist appointment making would happen. So that certainly helped dramatically, in neurology. If you can think about all of the headaches, severe headaches that are being referred into neurology. And so that really helped, as well as training of the primary care providers of how to manage those patients in the primary care setting, had a significant impact on that early on drop. Moving on, what we also did, item number 2, and there are a bunch of these, so I will not go into depth in all of them, but items 2 through 9 were really all operational measures. Number 1 was really kind of a clinical focus, and then we have spent a good amount of detailed work on items 2 through 9, which really are all operational metrics. And by that, we found, for example, you saw the reduction in orthopedics. We saw an opportunity. The APPs were being used as support to the orthopedic surgeons. And we saw an opportunity for the APPs then to develop their own schedules, just like we have in primary care, and have the APPs being used for all follow-up appointments. That enormously increased our capacity so that the new patients that did go through the clinical support decision-making process were eligible for an appointment, and all the new patients could be seen by the orthopedic surgeons. But then all the follow-up care could be done by the AAPP. So that's an example of where we really expanded capacity by fully utilizing our APPs. We also have expanded days in the clinic, the amount of time the providers are in the clinic to open appointments. We have also expanded, if we go to number 4, we are very focused on using our new regional health centers out in the community, not just as primary care homes, but also as specialty care access points. We've expanded cardiology pretty much across Arlington Heights, Sangstack, North Riverside, Belmont, Cragen. We've also expanded, that's just one example. We've also expanded rheumatology. We've expanded dermatology to expand our footprint and again, increase access. We have taken a very close look at those appointment templates. There's always opportunity in every appointment template. Maybe we found that there were more appointment types than we needed, and we needed to simplify to 3 appointment types because we found that there were no new appointment slots, but there were potentially other type of appointment slots that were going unused. So we did converting of appointment slots. We found that in the review of those 20,000 backlog, there were numerous duplicative orders in there and reduced those. We started direct scheduling in primary care. So when one of our primary care patients was leaving, they had gotten their referral to get that specialty care appointment. They could immediately in their medical home get an appointment to specialty care right away. We've also added surgical navigators to some of our surgical specialties, which ensures that the patient is being followed through from the time that they receive the referral and are appointed and are followed up in their care. And then we've taken a close look at providers that are under productivity Their show rates are less than where we need them to be, and then increase their appointment templates by providing more overbooking. So this combination of tactics is what has really shifted the needle on our backlog in referrals. Moving on to the next slide, just gives you a sense of where we're going forward. We are working with HIS and Angela O'Banion and her team on a RFP, or it's soon to close the RFP that would help us with electronic ease of external referrals into the system. We know we have a huge opportunity with our FQHC partners to offer them access to specialty care, but we need to provide a process that ensures an easy referral and also easy results back to the FQHC. That RFP and that we're looking for a vendor that can do that, in addition to the next point of helping us with the self-scheduling tool. We will continue also working on, with that tool, with the vendor, hopefully also improving rescheduling so that when a patient cancels, makes it easy to reschedule immediately, so not to leave no-shows, so to not continue to increase our no-shows or our last-minute cancellations. We will continue to expand our specialty footprint with our regional outposts. And then, of course, we will, in terms of just overall specialty clinic operations, we have a continued focus on just workflows and improved operational improvements. That concludes my report and update.
Thank you. Director Harrington.
Yeah, I just wanted to commend you and your team for the work that you've done and having it result in significant progress moving forward. Continue the good work.
Thank you, Director.
Director Story.
I just wanted to piggyback on Director Harrington's comment. Ileana, this is mighty impressive. Congratulations to you and your team. This is really a real structural change. I'm really impressed, very much so impressed. Congratulations.
Thank you, Director.
Great job.
Yes, we have an amazing team. Thank you.
Director Garza.
Yeah, thank you. Also want to add my comments. Very impressive work, and just shows really your passion, your caring for the people you guys care for. So thank you for all of that.
Thank you.
Yeah, so this is Karen Kim. I really want to echo the director's statements in terms of congratulating you on sort of system-wide change. I have one question though, in terms of some of the changes that you've made, do you have a committee that includes providers in thinking about ways to address the system and maybe the fragmentation that happens to reach specialty care? Are they involved in some of this decision-making?
Yes, so our medical director, Dr. Sharon Irons, and Ratna Kanamori, who is an APP, they are key partners in the work that we do together. They fully engage the chairs and the providers of each specialty area. That clinical decision support was done in full partnership with them, with their engagement, with obviously their clinical knowledge. So they're fully engaged in that, in the operational efforts as well. We work with them. Let's say, for example, double booking and overbooking is not very welcomed necessarily by any provider. We do not do that without the cooperation and the active participation of the chairs. We review the data, we demonstrate to them, look, these are the providers that are underproductive, overproductive, what should we do? They are in full, and we communicate with the individual provider as well. So yes, it is a strong partnership with the providers.
That's great to hear, particularly with burnout being such a problem. I think transparency in process is important. Thank you. I see hand raised, Tanya Sorrell.
Hi, thank you so much. This is an excellent report, and I really want to commend you, particularly in the improvements that you've been able to make in the behavioral services referrals and decreasing those delays to care, particularly during this time and the consistent areas that sometimes we notice for behavioral health services. I'm wondering what your area has discussed in regard to increasing the utilization of telemed or other types of services for appointments or follow-up appointments to decrease potential barriers for transportation and other ways to engage in patient encounters, particularly in behavioral health, which is now really expanding through the use of telemedicine.
Thank you for your question. We're currently, we actively looking at our no-show rates, and we are actively reaching out, have an effort in our clinics to reach out to those no-shows to better understand why they're missing their appointments. Is it because of lack of transportation? Is it because we appointed you out too far out? Is it because we didn't remind you? Although we have all of those functions in place to support the patients. And that is going to be eye-opening information for us to see, okay, well, we found that out of our research, 60% missed because of patient transport. So let's see what our opportunities are to expand that to ensure they get access. So patient transport is definitely one area that we're focused on seeing if that is something that we could respond to increase utilization in that area. As it relates to telehealth, we are, because of the pandemic, that is the highest utilization, at least in the ambulatory area, of telehealth right now. We provide the option of in-person or telehealth, so the patient has a choice to choose. In addition to that, however, we are working in partnership with our HIS team and Angela O'Banion as one of the efforts of our strategic plan on a virtual care service that would, potentially patient calls in, they may not have an appointment per se, but are calling for a virtual care visit and could immediately be cared for that virtual care visit in calling in. So more of a immediate response, and they would be have available of a provider, of course, that would be an immediate response type of appointment, and then we would link them into our longer term services. So there's absolutely more to come on that, and that we are currently working on.
Sounds great. That's a wonderful way to encourage that engagement, and that will then help with decreasing the no-shows or cancels following up to that. So great job.
Thank you. I want to thank my team. We really have an outstanding ambulatory team. This is the same team that brought up refugee health, the same team that did mass fax, a very committed group of people. And it's really a pleasure to be part of the team and lead them.
Thank you. This was a really great presentation. So we appreciate all of your hard work and effort, you and your team. I'm going to move forward with item 4 on the agenda, which are action items. Right now, we don't have any appointments or reappointments that need to be approved. I'm going to provide a very brief, before we move on to our EMS and MEC reports, I'm going to provide an update on our recent meeting of the Joint Conference Committee, or JCC, which was held on the 18th of January. Among other duties, the JCC provides liaison between the board, hospital administration, and medical staff. And it really provides a forum for discussion of issues that arise out of interest to all parties. So at our January meeting, we discussed non-union physician compensation and research clinical trials. The EMS noted that the compensation discrepancy between union and non-union physicians is making it very difficult to recruit quality candidates for department and divisional chairs. And it was recommended that the CCH administration provide changes in compensation to non-union physician leaders to mirror the annual pay increases and incentives that are given to physicians who are members of the union. It was also noted that the CEO is currently finishing up policies and working with administration and individually with department chairs to include a 3-tier plan with an end goal of reevaluating market salaries by dollar amount. With regards to the subject of research clinical trials, EMS expressed concerns that the clinical trial pause might negatively impact the ability to retain talented young physicians, and that the organization was missing out on an opportunity to enroll our patients in much needed studies. And it was recommended that the administration take every effort to restart new clinical trials as soon as possible. I want to say that the next JCC meeting will be held on April 2023, and at that time we'll include follow-up items to areas that were discussed during the meeting. I'm going to move on to action item 4B, which are MES, MEC reports, and I'm going to turn the floor over to Dr. Ekin-Toren, who will present the Stroger Hospital medical staff action items for our consideration. Dr. Ekin-Toren?
Yes, good morning, Chair Kim. Thank you. Thank you. Good morning, directors. I do have before you, and I'm presenting the credentials committee report as approved by the EMS and the presentation for your consideration. This credential report shows the medical staff appointments, reappointments, and changes. Thank you. If there's any question about that, I would pause for a moment to take those. Okay.
Thank you.
Yes. Yeah, thank you, Dr. Kim, and the rest of the reports you've presented. So thank you.
Thank you. I'm going to turn over to Dr. Mark Loafman, who will present Provident Hospital medical staff action items on behalf of Marlon Kirby for the committee's consideration.
Thank you, directors and colleagues, for allowing me to join you this morning. So the credentials report is submitted in total along with the Stroger report. Quite a lot of activity, clinical activity, all positive movement as we begin. Just continue to work on staffing. The QPI for the last couple of months, nursing continues to work on some pretty high success rates for multiple parameters that they're using in some areas that we know were identified in the mock survey that they're beginning to bring into the QPI process as well. So for the ER, it's the throughput, left without being seen, average length of stay. They're looking closely at transfer to 8 West for the patients that are staying there now. So looking at ways to optimize that length of stay and getting patients upstairs faster for that. So those are some of the highlights from ER nursing. Infection control, again, stellar success with hand hygiene, lots of good engagement in the audits for that. And overall, the parameters in the 95 to 100% range for that. Food and nutrition reported on their improved staffing now and more rounding and more consultation with patients, more direct communication with the interdisciplinary teams on there. And those are some of the highlights. That other areas are also included in the report. But that concludes what I have to report out to you today.
Thank you. Are there any questions? I'm seeing none. Thank you for the report. Again, we'll hold for combined motion at the end of this section. So the December and January QPS minutes were approved by the board at the January meeting, but are included for review and discussion. Please let me know if there are any corrections that need to be made to the minutes. Okay, I'm not seeing any. So I'd like to entertain the following combined motion to approve the following. Approve item 4B, Stroger Hospital medical staff appointments, reappointments, and changes. Approve item 4B, Provident Hospital medical staff appointments, reappointments, and changes. Accept item 4C, the December 16th meeting minutes, and accept item 4D, the January 19th minutes.
I'll make the motion.
Can someone second?
Madam Chair, you can second if you'd like.
I will second. So the combined motion has been made and seconded. Madam Secretary, please take the roll call vote on the combined motion.
Roll call vote on the combined motion. Aye or nay, Director Garza?
Aye.
Director Story? Director Story? I will circle back to him. Chair Kim?
Aye.
And circle back
Debbie?
to Director Story. Are you present,
Aye,
Director Story?
Debbie. Aye.
Thank you very much. So Madam Chair, you have 3 yeas and 0 absent.
Okay, the ayes have it and the combined motion carries. The committee will now be going into closed session. Action is not anticipated to be taken in open session after the closed meeting has adjourned. I'd like to entertain a motion to go into a closed meeting pursuant to the following exceptions, the Open Meeting Act, 5 ILCS 120-2 C 1, 11, 12, and 17.
So
I'll make the
moved.
motion. Seconded.
The motion has been made and seconded. Madam Secretary, please take the roll call vote on the motion.
Roll call vote on the motion to go into closed session. Aye or nay, Director Garza?
Aye.
Director Story?
Aye.
And Chair Kim?
Aye. So the ayes
You
have
3
it.
yeas.
Oops, sorry.
Thank you. Sorry, go ahead.
No, you have 3. Go ahead, Madam Secretary.
You have 3 yeas and 0 nays.
Okay, the ayes have it and the motion carries. So we will now go into closed session.